want to introduce Dr. Bonnie LaFleur. Bonnie.
Thank you. That's okay. Can you hear me okay? All right. So I'm going to kind of follow on what everybody else has talked about in a sense, but I'm going to bring it to the clinical side. So going back to something that that George alluded to is this idea that dietary restriction has been shown to improve health span in older adults. We know this, and there is a good mimic of that kind of dietary restriction in a drug that I think everybody here has probably heard about, and that is rapamycin. So I will tell you that I'm doing a little bit of a bait and switch, because originally I had planned on talking more about the biomarker side of things because I wasn't sure whether or not our clinical trial was going to be widely known about before this event, but it did go out. The press is out. We're actually undertaking one of the largest clinical trials in rapamycin to date at the University of Arizona. And so I'm going to talk a little bit more about that. And then I'm going to talk about some of the things that we've done to support and get prepared for that clinical trial. And then I will come back to the biomarkers, which kind of feeds into a lot of the other talks that we've heard this morning. So first of all, our study. We're going to do a double-blind randomized placebo-controlled trial. We're going to give weekly low-dose rapamycin and a manufactured placebo that Thermo Fisher is manufacturing for us. We're going to treat people for 2 years with an additional 1 year of follow-up. And then we're going to be taking a lot of biospecimens along the way, both for safety purposes, since this is a very long-term clinical trial in terms of what's known to date, but also because of the opportunity that we have not just to evaluate how rapamycin is actually affecting a lot of the types of systems that we've heard people talk about today, but also because it gives us an opportunity for the next set of clinical trials that could be operationalized. So we are going to be randomizing 720 participants, 65 years and older. We're screening for people who are pre-frail, given the Fried Frailty Index, which is a score of 1 to 2, with all of these 5 criteria. Each criteria that a person has is 1 point, so we're looking for people specifically who are in the 1 or 2 range in terms of scores. We're actually going to balance these people by immune profiling. And part of the reason for that is that we want to make sure that at the end of the trial, we don't have all just very immune healthy people, because we feel that there's a possibility that rapamycin is likely to have a better response in certain people than others, and we want to make sure that we're not oversampling only healthy people. We want a fairly full complement of immunity in these people. So our primary endpoint, which is really cool and took a little bit of clinicians bringing me along, because I'm a statistician. I really like quantitative measures. I like things that can be measured and that I know what the variation is and I can measure those things. However, one of the things that people care about a lot is this transition to frailty. They might not be able to talk about that construct in quite that way, but that transition from a pre-frail state to a frail state has a lot of implications just in people's daily lives. So we're actually looking at that transition from a pre-frail to a frail state as one of our primary endpoints. We're oversampling for unintended weight loss co-occurring with either low activity or weakness, because those two of all of the 5 criteria, those type of criteria are actually associated with the highly deleterious effects of this transition. It's about a prevalence of 20% of pre-frail people typically will transition within a 2-year period. So if we follow them for 2 or 3 years, we're hoping to actually see in our rapamycin-treated group that that is going to be less than the current state. We're also measuring IL-6, which is more of a quantitative measure, and this IL-6 is sort of it's a surrogate measure for chronic inflammation. And it's been associated with accelerated brain aging, disrupted metabolic health, and also cardiovascular events. So just to reemphasize that this transition to a frail state is actually a really important indicator of both physical and psychologic and social well-being in older adults, and it's something that the older adult population cares a lot about. And then we actually, at the University of Arizona, have also been conducting a very long-term, now entering into year 6, neuroscience-based study called the Precision Aging Network. That study is really looking at the neuroscience or the cognitive, we're trying to get the trajectory of normal cognitive function in healthy adults. As part of that, though, we have also shown in that study that the prevalence rate of this pre-frail state here in Arizona is still approximately 20%, 23%. So we're actually seeing this estimate of 20% play out in real time through the course of evaluating this as part of the precision aging study. And just to show the importance of IL-6 and how that is actually correlated with our other outcome, which is frailty. It's almost like, I'm just going to talk statistics for just a minute. We actually, IL-6 and the transition from pre-frail to a frail state is actually highly correlated. So these two outcomes are basically measuring similar things, just in a different way. And so this plot actually shows that if I measure this in 2 different assays where I'm measuring IL-6 in plasma, I can actually show that this pre-frail population compared to a not frail population, there's an increase in this chronic inflammatory state. I'm showing you 2 different assays because it's important to know that how you measure these things and with the precision that you measure them, you're going to find higher correlations. One of the new pieces of information that we have as we are preparing to embark on this clinical trial is we didn't know what dose. What is low dose? Everybody talks about low dose rapamycin, but the literature, there's just not a lot of literature around this. And so Matt Kaberlin, who everybody here is talking about, actually wrote a paper in Neuroscience, and he had a survey for people, a survey that people participated in who are taking off-label rapamycin. And it was just sort of like, what dose are you taking? How frequently are you taking it? And he showed that the most frequent dosing was a once a week, and it was 6 milligrams per week was what most of the participants were taking. But it ranged from anywhere from 3 to 10 milligrams per week. There is also a Pearl trial, which I believe they're here. They started a company called Ageless, and I don't know if they're in the audience, but they had actually manufactured rapamycin as a supplement, and they were looking at 10 milligram and 5 milligram and 10 milligram doses, but because of the manufacturing process, they had actually found that their compounded formulation was really equivalent to about 1.4 and a 2.89. So that was a little bit difficult. They never actually got to that 5 and that 10. So we decided to split the difference and look at a 4 milligram per week and an 8 milligram per week. And we had 2 co-primary endpoints for this, where we were looking at trough levels because we were trying to make sure that we're not hitting that immunosuppressive pathway, which rapamycin is currently used for. And that is, usually we look for anywhere from 5 to 15 nanograms per milliliter. And if you hit that, then you're actually hitting that that immunosuppressive pathway, which if you're getting a solid organ transplant, that's where you want to be, but we don't want to hit that. And then we also were measuring 2 immune targets in phospho-6F kinase and phospho-AKT. And what we showed was on the left-hand side of the screen, you'll see what happened from baseline and 8 weeks of follow-up, looking at phospho-S6 kinase. And we can see that there is a more rapid decrease in the 8 milligram per milliliter, or 8 milligram per week dose compared to the 4 milligram. We don't see any change really in AKT. And I got to tell you, I wasn't not that surprised. That's what the literature sort of suggests. But I was excited about this because there has not also been that much evidence to suggest that phospho-S6 kinase can actually be evaluated very well. We did use, this is from flow cytometry. So it's a really cool result, and I'm very excited that we're writing the paper up now. So noteworthy, we didn't see any real safety endpoints here. So we had only one person who actually had any level of rapamycin above the detection limit. It was it hit about 4.5 nanograms per milliliter. They didn't drop out. They didn't have any side effects. It was just a trough level, but that was 1 out of 50 people, and it was actually at the 4 milligram per week dose. We did also genotype people because we were a little concerned about people with some of the CYP genes that might either be fast or slow metabolizers. With the fast metabolizers, perhaps accumulating more quickly, and then the slow metabolizers maybe not even getting the accurate dose. We didn't really see very many of those, which I can tell you as somebody who's operationalizing this clinical trial, I was really relieved because I didn't want to really have to pay to genotype every person in the clinical trial and all of the screening people as well. So this was also really interesting data that I don't think I've seen that much on yet. All right, now I'm wrapping up. Opportunities. Now I'm going to come back to my biomarker stuff, which is like my thing that I'm interested in. We all have seen and heard that chronologic age probably is not an adequate measure of health. We all know this. There's several age-related biomarkers that have been proposed, including the epigenetic aging. There's also, I really like this, there's a Lin age, and what they did was take the epigenetic clocks and then add on these chemistry and metabolomic panels to that, which are things that you just collect just routine blood work. And they actually showed that it really amplified some of this epigenetic changing that we've seen in terms of estimating biologic age. I really like that. What we're doing is extending that even a little bit further, and I'm calling this a resiliency-related biomarker because I'm really interested in whether or not we can either clinically or subclinically find people who either maybe should not be receiving the most invasive procedures. For example, I'm working in non-melanoma skin cancer, which is a chronic disease in older adults. Having a Mohs surgery in a person who perhaps could have a high probability of morbidity, having those invasive procedures perhaps should be pushed into an alternative approach. There are many others. And so that's kind of like my idea. And so as a part of our clinical trial, we are measuring immune aging through a flow cytometry assay. We're working with a group from Israel who actually has a really nice immune profile. They have a company. Israel is actually a payer-provider kind of a network where their universities are very tightly coupled to their healthcare delivery system. And so it's almost like universities are in fact seen as incubators for the types of biomarkers that could help direct patient care. We're also looking at chemical aging, as we know, in addition to other types of pollution and heat stresses. We have UV exposure. You can actually measure chemical aging using non-invasive skin measurements and also UV light, which a lot of dermatologist offices use. So we're capturing that data through our screening process. We're looking obviously at epigenetic ages, but we're also incorporating functional and psychosocial measures of resiliency through surveys. And then we're going to also include the common blood markers. We also are hoping to be able to do some DEXA scans because we know the shift of adipose tissue in older adults has a lot to do with what happens to people in terms of frailty. So our goal actually is to help inform patients and providers on the cost of benefits of various treatments that aren't necessarily geroprotectors, but I also believe that we can also predict response either to rapamycin in our study, but also some of the other therapeutic interventions that are on the horizon. I'm very excited about NAD+, so I was really glad to see that on the slide. But that's where my biomarker work is going, and my goal is to strive for generations of superagers.
So our next speaker had to cancel last minute, so actually we're back on schedule. So that works for us. Absolutely, please.
So I also want to say I brought these cards. Matt Kaberlin is coming to U of A next Tuesday. I put these cards over on that side, but I can also put them here. There is a Zoom option, so if you guys want to grab these, it's going to be really interesting. He's on our scientific advisory board for the clinical trial, so we've invited him to come to the U of A. It's kind of like a kickoff speaker, but highly recommend it. He's a really awesome speaker, so you guys, I would like to invite you.
He's also on our board of directors.
Oh, there you go.
This guy's everywhere. It's crazy. Yeah, I know. He's a magnet. Okay. Well, Bonnie, if anybody had any questions for Bonnie, I'm happy if you want to come up and take questions. We now have plenty of time. So, here, does anybody have any questions?
A lot of people are interested in this, and I think that right now except for so we're doing arthritis surveys, we're doing some skin surveys, we're doing spirometry measures. There are a lot of we're capturing biospecimens, but we don't have the money to run everything, but we are doing stool and buccal and tons. I mean, we're bleeding these poor people like crazy. So I'm not sure exactly which ones, but we're trying to phenotype. So we have to screen about 3,000 people to get to the 720 that are going to be eligible for our study. So those people are as deeply phenotyped as I can get within the constraints of a budget. But the idea here is to be as inclusive as possible for the many scientists who have a lot more knowledge than I do about these phenotypes that you're thinking about. And there's a lot of opportunity for ancillary studies. And so that's the goal, I think, that we've had is we're viewing this first 200 people that we're screening as a real opportunity to kind of have preliminary data. And then we can amend our IRB protocol for the screening part. We're separating the screening from the clinical trial because I had to get an FDA IND to run the clinical trial, and I didn't want to get into the whole how are we recruiting people bit. So, but it adds this really nice opportunity for us to do just that.